expiration or inspiration, breathing motions. At the end, I agree. Also consider the special case that is a very young woman is with not good prognosis because is a cancer in pregnancy, and so we know that the prognosis is worse with respect to the others. So just a practical question. So you have considered, you have seen that probably is not so large breast, maybe 4 or 5 centimeters up to the chest wall. If you have also considered the possibility to give electrodes. Yeah. Ah, okay, sorry. Okay. Yeah. Okay.
Thank you, Dr. Enrique. Dr. Ihab Khalil, you gave state of art. What is the future is coming? Sorry. Yeah. You did a very good conclusion to the day by speaking about moving to a new era, a new state of the art after all of these accumulated experiences and trials. And I need a little bit of a moment of comment about what Dr. Sabri has presented to us. Is it suitable for our daily life in a very busy institute? You are having a busier, even busier than ours in Ain Shams, in the National Cancer Institute. Would you feel that manipulating the system, if I can say the word, and pushing everything to the limit this way can help us overcoming the expense, the time, and get our younger colleagues to be trained to find new solutions for our daily problems?
Well, it's a very long question.
It's your experience, your comment in your words. I'm sorry.
But I agree, definitely agree with Dr. Enrique. I just told my professor that personally I would try electric first because this is the simplest technique. The chest wall is small, and I've noticed that during the presentation that the CTV was at the chest wall, but we could have in this patient as said that she was already negative, she didn't have any disease. So we could have shifted the CTV to the anterior of the pectoralis major, and this would also give us some chance in doing field and field. The forward IMRT with 3D might, with a very good trained and experienced physicist, it might have given us a good LED dosage. So these are good things, but the important thing is training patients and waiting in between session. Of course, I didn't catch from you how many minutes did it take to treat this patient? About 6 minutes. This is very patient.
In a busy department, it's a good solution for everyone.
But the issue is that it was selected because it was a gated edge, but you didn't have any gated edge. So you just counted on the patient is taking the gated edge, but this is subjective. Without gated edge, you have to focus on people, you have to take a CT.
Monitoring the over and over.
This is a metric issue. You know what's the event inside the
Just one little comment. This technique is very used in the several European countries, in the Netherlands, and Professor Philip Portmans used it in the daily practice for the left breast.
Patient by patient, only instructing them and without doing IGRT?
The control of respiration?
Yes.
Without IGRT?
Without.
Yes. Yes.
And
Training occupations?
Without gating?
Without gating. Just controlled respiration.
Then you have the good points.
Now we will move to next speaker, Dr. Ahmed Saeed, lecturer of clinical oncology, representing the gynecological unit in the Chance Oncology Department,
for the next case presentation. Doctor.
Thank you, Mr. Chairman. Thank you, Dr. Khaled, for inviting me for this session. Again, I will present a case from our daily life in gynecology unit. So this is Mr. and Mrs. AA, 61 years old lady, para 3+0, presented to our unit 3 weeks ago, almost at the time Dr. Khaled called me to have this case presentation. With no past medical history of medical importance, she complained from mild vaginal bleeding about 8 months ago, sought medical advice at her primary health care hospital, and after medical examination suspected to have cervical lesion. DNC were done for her, and his pathology report documented that section examined fragments of endocervical tissue infiltrated by non-keratinizing large cell squamous cell carcinoma. The decision of her primary team was for neoadjuvant chemotherapy for possibility of radical surgery, and here we have in Egypt only 2 places to have brachytherapy for cancer cervix, and this is shifting the paradigm of treatment of cervical carcinoma into selecting cases that maybe benefit from neoadjuvant chemotherapy to be followed by surgery, rather than giving this patient a radical treatment rather than incomplete treatment protocol by giving external beam radiotherapy, and we don't know yet will she receive brachytherapy in time or not. So we have, but through MDT and clinical trials, so we have one good MDT in our unit with collaboration with our gynecology surgeons. We are discussing cases there, case by case, in presence of the radiation therapist, medical oncologist, and the surgeon, beside radiology expert and the pathology, and we do select some cases for that protocol, that cases with 1B1, 2A, 1, or even 2B with minimal parametric infiltration to neoadjuvant chemotherapy, and we evaluate that for surgery because of the lack of brachytherapy actually in Egypt, and even it's given not in the same time, sometimes delayed, sometimes not given at all. So, but unfortunately this lady received 6 cycles of paclitaxel carboplatin with interior radiological assessment by CAT scan reporting partial response. And we again revised all the investigation for this patient at our department with the expert. But after the 6th cycle review, the CAT scan reported rather a stationary course compared to the previous study. So she was referred for surgical assessment, and EUA revealed a large cervical mass, including posterior and left vaginal fornices, with left parametrial infiltration reaching the pelvic side wall. And that was not discovered by imaging. This is by clinical examination and examination under anesthesia. The patient then referred to our unit, accepted as stage 3B cervical squamous cell carcinoma. So this is the pre-treatment MRI, and I have this comment from an expert radiology that a small lesion is seen in the posterior cervical vaginal junction with posterior and lateral vaginal fornix affection and left parametrial infiltration. And even though the lesion was not that clear in MRI. And the post-treatment CT at the end of the 6th cycle, the CT can precisely assess the mass because we cannot compare CT with MRI, but apparently it is larger compared to previous MRIs. So we offer the patient the radical treatment involved external beam radiotherapy, and the patient will be transferred for brachytherapy. We have the target delineation and organ at risk. So what we see in red is the visible cervical mass, and in orange, the parametria. This is the bladder, and this is the rectum. This is from another level. We have here the lymph nodes. And the final planning target volume that included the cervix, the parametria, and 3 centimeters of the vagina, plus common iliac internal and external iliac lymph nodes. As we can see, Patient was planned for 3D external beam radiotherapy of 50.4 grays, 1.8 gray to fraction for 28 fractions, 5 fractions per week, concurrent with cisplatin, 40 milligrams per meter square per week, to be followed by brachytherapy. And this is DP edge. We can see that the planned target volume and the gross target volume are receiving adequate treatment. The bladder, bowel, femoral, and rectum are within the tolerance zone. As you see, this is the blue C color for all the planned target volume. The red one is for the gross target volume for the cervix. As you see, that's for femoral, rectum, and bladder. This is 95% color wash, showing adequate coverage of all the planned target volume, with only 1.4% hot point. This is the 4 fields given. Classical one. And the DRR for the anterior and left lateral field. We see here we cover the common iliac as it is boundary disease. We cover all the common iliacs, and we cover almost more than 3 centimeters of the vagina beyond the cervical extension. So, definitive radiation therapy for an intact cervix. In patients with an intact cervix, those who don't have surgery, the primary tumor and regional lymphatic at risk are typically treated with definitive external beam radiotherapy at a dose approximately 45 grays. The volume of external beam would depend on the nodal status as determined surgically or radiographically. The primary cervical tumor is then boosted using brachytherapy with additional 30 to 40 gray to 0.8 low dose rate equivalent dose for a total 0.8 dose of 80 gray for small volumes and for more than 85 grays for large volume cervical tumors. Well, we all know that. Grossly involved unresected node may be evaluated for boosting with additional 10 to 15 grays of highly conformal and reduced volume external beam, and here comes the role of IMRT. Intensely modulated radiation therapy and similar high conformal method of dose delivery may be helpful in minimizing the dose of the bowel and other critical structures IMRT post-hysterectomy setting, as is established. This technique can be useful when high doses are required to treat gross disease in regional lymph nodes. But as mentioned here, we are a low resource country and we don't have the luxury of treating IMRT for our patients. We are treating more than 80 cases in each machine, and our colleagues in the breast units are taking most of the time in the physics units with only 2 stations. With only 2 stations. Yes, with only 2 stations available for delineation as well. And IMRT, you know that you have.
Pushing your luck.
Yeah. Dr. Muhammad Sahi was my professor and he teaches me a lot. And you'll accept that from me. So, when you deal with IMRT, take too much effort in delineation, and also don't forget the verification of what you did. What you done in the case. You cone beam CT, and you need to verify the target that you have planned that is already given to the patient without geographical miss. This technique, as I said, helpful when high doses are required to treat gross disease in regional lymph nodes. However, conformal external beam therapy such as IMRT or stereotactic body radiation therapy should not be used as a routine alternative to brachytherapy for treatment of central disease in patients with an intact cervix. And this is outside clinical trials. Very careful attention to detail and reducibility, including consideration of target volume, normal tissue definition, patient and internal organ motion, soft tissue deformation, and rigorous dosimetric and physical quality assurance is required for proper delivery of IMRT and highly conformal technology. And this is we miss as resources and time also. Routine image guidance such as cone, beam CT should be used for defining daily internal soft tissue positions. Thank you very much.
Thank you, Dr. Ahmed, for your this nice case. And now, any comments or questions, Dr. Ahmed, about the last case? Okay, and Dr. Okay, yes. Yes.
It's a very correct term, and I'm proud that this is on daily basis will be like
Okay, now for the question for the first two speakers, Dr. Ihab and Khalid Shahan, if anybody of the audience want to ask or comment about the first two presentations? Yes. Dr. Khalid. Yes. Yes. في مايك.
Well, in clinical practice, as we said, the practice changed to be evidence-based, and we have evidence that boost for patients less than 50 years of age and less than 40 was having a better recuperation of life-free survival. So we have to embark on whether this patient is doing an air or doing a beak for phase time. And if we have a patient with a 2 by 2 centimeter with an excision of a 5 by 5 quadrantectomy, then we can definitely plan boosting this patient. So it depends on the biology, it depends on the surgery, and it depends on the yes, and on the clips localization.
Okay, my question, Dr. Ihab, regarding breast cancer again, because it's a very common disease, and every day we have many patients, and again comparing IMRT versus 3D conformer. Do you have enough cost-effective study comparing IMRT and 3D conformer in the adjuvant treatment of breast cancer?
Cost benefit, as you said, I think one of the slides that said that 3D API is cost benefit then, and in a 3D fashion, if you are using API, then you are increasing the dose of the lung and the heart and even the contract reserves. So the cost depends on patient selection. But in order to say 3D versus IMRT without selecting the patient, this is...
Can I say in other words, if you have, like us, like you, a very busy center and a very crowded center, who is the patient that you are going to select to give her IMRT? You are going, this patient, she is going to receive her adjuvant treatment by MRT, not conformal.
Patient selection will depend on achieving the orbit at this constraints. If I can achieve this by 3D or forward IMRT, presentation then it's doable. Otherwise, around, I will go to IMRT.
Yeah, of course.
In our institute, yes, we have some cases where we have a very acute chest wall, we have cannot achieve the constraints, we can shift IMRT. Those patients get transferred.
Any other question? For the second presentation, Dr. Khalid. Okay, Dr. Khalid Abdelkarim.
Thank you so much for your presence today. It was a joy. A lot of discussions have been done, and I would kindly remind you that this is the conclusion of today's gynecology and applied radiotherapy sessions. But tomorrow, inshallah, after Salat al-Jum'ah, Friday prayers, at 1 sharply, we will discuss the radiotherapy of the breast. I think we will have a lot. I'm sorry. It's 1:30. Okay, you know better. So it's 1:30 p.m. tomorrow, and I'll ask the presenters and the chairpersons for a group photo, please.